Hello and welcome. Thank you for joining our conversation today, Bridging the Gap on Behavioral Health, Advancing Whole Person Care Through Integration. My name is Muriel Lemoy with Blue Shield California's Industry Initiatives team. We work on advancing healthcare transformation through industry alignment and policy movement. You can learn more about our work and stay up to date by visiting our website and signing up for our newsletter. Link is in the chat. We have an incredible panel with us today who you'll meet momentarily. We've got Christine Mercado from Common Spirit Health, Crystal Eubanks from California Quality Collaborative, Sharmil Shah from the California Department of Healthcare Access and Information, Mariana Torres from California Healthcare Foundation, and our own Jennifer Christian Herman from Blue Shield of California. Each of these panelists is working from their different sectors across the healthcare system to drive improvements in behavioral healthcare. With nearly 1 in 7 California adults experiencing a mental illness, integrating behavioral health resources into primary care and other medical settings has emerged as a powerful tool to drive improved access to effective and timely care. Our panelists today will be sharing their experiences working to advance behavioral health integration at their own organizations and beyond, including opportunities for us to work together to reach the full potential of integrated care. Thank you all so much for taking the time to be here. It's going to be a great conversation. At this point, I would like to invite our panelists to join me on screen and to introduce themselves and share a bit about their work and how it relates to behavioral health. Christine, can you please get us started?
Absolutely. Thanks, Muriel. Thanks for having me. I'm the Vice President for Strategic Innovation at Common Spirit. Common Spirit is the largest not-for-profit health system in the country. We have 140 hospitals, 2,000 plus care sites across 24 states. And in my role, I help transact strategic partnerships on behalf of the organization. I also sit on our behavioral health leadership team. So in that capacity, I've been developing our enterprise strategy with a focus on equitable access and sustainability for behavioral health. And I'd say that over the past couple of years, Common Spirit's really made a lot of bold moves to address our population's mental health needs. We launched our collaborative care program in early 2020 through a partnership with Concert Health. And since then, we've developed several other behavioral health partnerships and programs, including in the area of acute psychiatric care and serious mental illness. So I'm really excited about today's conversation because clearly, poor mental health is the epidemic of our time. And so if we really want to make a difference on the population in California, we need to treat people's mental health and medical care together holistically. And BHI is a great example for how to do that.
Thank you so much. Jennifer, let's go to you next.
Hi, I'm Jennifer Christian Herman. I'm the Vice President of Clinical Strategy and Programs at Blue Shield of California. And as part of that accountability, I am responsible for our enterprise strategy to transform behavioral health. And this work around collaborative care and integrated behavioral health is a key pillar of that. So I'll share a little more about that shortly. A little background, I'm a clinical psychologist. And I'm just finishing a mental health policy fellowship with an organization called Inseparable. And my work there, my project there has focused on barriers to scaling integrated behavioral health. We know it's a great model. It's been around a long time. How do we move it forward? And particularly, how do we look at both policy and payer levers to actually help to scale and advance this work?
Thank you. All right, let's go to Crystal next.
Hi, everyone. I'm Crystal Eubanks. I have the pleasure of leading the California Quality Collaborative. And so we are a statewide healthcare improvement organization, and we work through a group of multiple types of stakeholders. And so how do you bring people together to solve our collective problems and issues? And even we work actually collaborate on projects. So we've long provided technical assistance, particularly to the ambulatory care space and primary care. That's been a big focus. And we, as a means to accelerate both access to primary care and mental health, we've long focused on behavioral health integration as the pathway that we can address the access gaps in the state. And help advance other pieces of primary care. We know that's integral to driving chronic disease outcomes and engagement in care for preventive care. And then I think from my own experience integrating behavioral health into primary care is to see the joy that it brings to the workforce. And I think about how beleaguered primary care is right now and all that we ask of them. And might this not be just a tool for quality, but as well to bring that joy back into that space of caring with patients? And so we come back to behavioral health integration should be a standard practice for every Californian, right? You should be able to access that anywhere and rather than be an outlier, an exception, or a bright spot. And I would add, I think any primary care team in California should be able to provide that care when it's needed and be engaged in a more holistic approach to help and treating their patient population. So we are currently leading a behavioral health integration initiative. It's a 5-year program. We're about midstream. We've been learning a lot about how to accelerate integration in different types of practices across different payers and patient populations. And so I'm excited to share a lot of that work with you. And part of that is not just the kind of technical assistance, but bringing stakeholders together for alignment. And so as Jennifer shared, kind of focusing on what are the policy and payment barriers to transformation and integration by practices, and how might we collectively solve some of those problems at the system level through alignment to kind of open the doors wider for practices to really deepen their integration efforts.
Thank you so much. Sharmila, let's go to you next.
All righty. Good morning. Thank you, Muriel, for the opportunity to be here today. I'm Dr. Sharmil Shah, and I'm a child psychologist by training and serve as the Assistant Deputy Director of Behavioral Health for the California Department of Healthcare Access and Information. Part of my role here at HCI and in the broader behavioral health ecosystem is to ensure 2 things. 1, to develop, support, and expand a health workforce that serves medically underserved areas, serves our Medi-Cal members, and represents the California it serves through racial and language diversity. Secondly, we offer programs that provide financial support for building the workforce pipeline, to expand educational capacity, to individuals pursuing health careers, and to supporting providers and addressing retention. Additionally, HCI will be receiving significant funding for behavioral health next year through BH Connect and Prop 1, where we hope to continue increasing the workforce needed to serve vulnerable populations who have behavioral health challenges. We are focused on ensuring that we have the right workforce that matches the communities we serve and focuses on whole person care with initiatives that emphasize integrated behavioral health, which I will be so very excited to share more about later on in this webinar. I'm looking forward to our conversation today. Thank you.
Thank you. And then last but not least, let's go over to Mariana.
Hi, thank you. Mariana Torres. I'm a program officer at California Healthcare Foundation, and I have a portfolio focused on improving mental health and substance use disorder services for Medi-Cal recipients statewide, with a special interest in low barrier services and eliminating health disparities. And so I really appreciate the opportunity to speak today, and I'll hand it back to Muriel.
Thank you so much. Thank you all. We're so excited to have you here. Our first question is for Christine and Jennifer. So when you're thinking about our current behavioral healthcare system, alongside your organization's goals for behavioral health, can you share why your organization has decided to pursue behavioral health integration and a bit about how that experience has gone, including any successes you might have had, as well as challenges you've faced? Christine, let's start with you.
Sure. Thanks, Muriel. First I'll address why we chose BHI through collaborative care, and then I'll get into some successes and challenges. I'd say that even before the pandemic, clinical papers were sounding the alarm about the real lack of therapists across the country. And so we started to ask our clinicians, and particularly our PCPs, what they were seeing in the communities. And they confirmed that among their patient panels, they were seeing increases in depression, anxiety for their patients at an increased rate. And what they would do is there were, maybe a handful of therapists in the community that they trusted, they would refer their patients to. And when those therapists were all full, they really didn't have a lot of alternatives. So they would closely manage the patient, closely, monitor them, follow up. And so we asked ourselves, is there a better solution? What could we do to support not only our patients, but our clinicians? And so we started to research various models, and we landed on collaborative care because of the strong clinical effectiveness that the model has. I would say that, we've launched the program since 2020, and we've realized some really strong successes. First and foremost, we're pleased that our patients are really satisfied with the program. They think it's easy, it's affordable, it's low tech. And so in our surveys, the program scores in the Net Promoter Score or NPS in the mid 70s, which is really high for healthcare. And so as a result, the program has been growing consistently. We're in 23 sites in California, 25 in the state of Washington, and next year we will see our 10,000th patient, which we're really excited about. In terms of outcomes, about 50% of our patients see their symptoms cut in half in under 4 months, and 60% of patients are graduating with a PHQ or GAD under 10. We also think this program creates more equity. One of the things our PCPs told us is if we're going to launch a mental health program, they want it to apply to everybody, not just those who know how to use technology, not just those who have great commercial insurance, but anyone who walks through their door and needs it. And the good news about collaborative care is that it's covered by Medicare, now by Medi-Cal, and most commercial plans. So we're able to launch it universally, and we're seeing really good results. We had a study early on in the program, and it showed that over 70% of patients using the program had never had therapy before. So to us, that was really directionally positive in the sense that patients were getting access who might not have had it before, or maybe they felt more comfortable using this particular program because it was connected to their PCP. So we continue to improve our program, and I'm still working out some challenges. I'll just quickly name two. Internally, this is not a set it and forget it program. It requires some good project management, even though we have a fantastic partner who also helps us with project management. But we really work on training and education for our physicians so that they know which patients will likely do best with this program. We spend a lot of time thinking about building strong communication pathways between the therapist and the PCP. And sometimes that's meant modifying our workflows. Sometimes it's meant changing our documentation because we want the right level of information going to the PCP so that it's actionable. And then externally, I would say we're still working through payment complexities. It's still early days for collaborative care. And, I don't think anyone's looking to use BHI models to make a lot of money, but we do need to make it sustainable. So we audit and monitor our financial pieces, I'd say, pretty actively. But overall, this program has really delivered and provided greater access for our patients.
Thank you. That part about reaching people who hadn't before access to mental health care, that's really incredible to hear. Jennifer, let's go to you to hear a little bit about the health plan perspective.
Sure. So we, as I said, we have a strategy around transforming behavioral health. And a really important part of that is building an ecosystem of care. So it's important that we have a strong clinical network. And we know that is not enough. That is enough to not enough to provide the kind of access that members need. It's also not enough to break down stigma that people may have around actually seeking mental health care. So we are strong believers and advocates in integrated behavioral health models, particularly the collaborative care model. And we started our work in 2020. And we really, when we looked at these models, we thought about access, but we also quickly realized just that these models really impacted every aspect of the quintuple aim. And Christine, you talked about equity. Equity is a really strong thing around this. And so we started by partnering with our provider organizations and folks in our network, and looked for partners. And Christine, you guys were an early partner who were interested in this model. We knew that it was a big investment, and so we started with organizations that were already seeing the value in wanting to do this work. We built these partnerships. We established a relationship and a contract with the AIMS Center around collaborative care, and used that to provide technical assistance and support for groups if that was something that was needed and helpful. And we found creative ways to partner and help to support implementation. One thing we think is really important is we identified an individual whose full-time job is leading this work around integrated behavioral health. And she serves as a point of contact for our provider groups, for others, for any question, any troubleshooting, any strategic partnership. And we know it takes a big investment to launch these programs. There's change management. Although the models are built to be sustainable, they're not necessarily sustainable in the startup period. And thinking about what are the ways that we can help to support that. We also know that the CMS reimbursement rates are not sufficient. And so we have adjusted and increased those rates. We're looking at things like, how do we eliminate copays for members? Like, what are all of the barriers from a financial and practical perspective? And how can we be a true partner to provider groups who are interested in implementing integrated behavioral health models? As I mentioned before, I'm doing policy work. And so Senate Bill 1320 is really important in that it mandates in California that all health plans have a mechanism to reimburse for integrated behavioral health models. So we think that's a great step forward, and we know it's not enough by itself. Just mandating something doesn't really make it happen, and this is complex. And so while we started this work, as a health plan, as a business, thinking it's the right thing to do, it's going to help with access, it's going to help with member and provider experience. It has impacts on equity, cost of healthcare. At first, it was like, this could be a great differentiator for us, but I think we very quickly have gotten to a place of realizing that this is not where any of us need to differentiate ourselves. This is a place where we need to come together as a village to really help to scale these models and increase access in this way. So that led to the industry initiatives work that Muriel mentioned before, and the partnership with CQC and with so many here to really think about how do we do this together, because we know for provider organizations, and we've heard loud and clear, doing it for one health plan or doing it differently if each health plan is doing it slightly differently certainly does not help with the models being sustainable. So with that, I'll just end with kind of along that theme. I think there's a sort of an old saying that if you want to go fast, go alone. If you want to go far, go together. And I think that's where we are now. We've been really proud of the work that we've done in partnership, and about over 1 million of our Blue Shield of California members now receive primary care in a group or in a practice that practices some form of evidence-based integrated behavioral health. So that is great success. But we also know to go beyond that 1 million mark, we're going to need to do that together. And that's what Californians really, really need from all of us. So excited to be here as part of the discussion today.
Thank you. If you want to go far, go together. That's a great saying. Thank you for that. So Crystal, we've just heard a bit from Jennifer and Christine about some of the challenges they've faced in expanding and sustaining their integrated care programs. And you talked about your organization's behavioral health integration initiative. So I'd like to ask if you could share a bit more about your organization's work in that area, particularly any successful practices we could learn from today, as well as opportunities for us to come together to address some of these remaining challenges.
Thanks, Muriel. Yes. So we are about midstream in a 3-year improvement collaborative called CalHive BHI, and you will see a link there. You can get all the resources and kind of updates on our groups. But just to share, this was launched mid-2023. And we are supporting 8 organizations, and these organizations represent different types, right? And they're small hospital systems, small independent medical groups, FQHCs, a large safety net system from the county. And so what we're learning across all these organizations and seeing what we can do individually in the organizations, but at scale, because they serve 700,000 patients across them, is you can do BHI in any kind of organization, right? And so we think about there are different constraints, there's different nuances. So what we have learned from those nuances is that organizations need to understand that there are different models of behavioral health integration. And so Christine shared about the collaborative care model, which is widely adopted in amongst those practices that have done BHI in California. There's also what we call PCBH, and so primary care behavioral health. And organizations have to need guidance to think through what is a sustainable model for them that both serves their patients, serves the different payer contracts that they have. And how do you then implement that model? So we've been kind of agnostic to models because I think different ones serve different practices and organizations in different ways. There's advantages, disadvantages, always trade-offs, but you can do it. And so I think the takeaway from this learning is that you have to be thoughtful. You have to have resources to even go through that process of consideration. So we are mapping all the funding codes, going back and looking at the contracts. But to think about sustainability from the beginning, because some of our organizations have actually tried to implement BHI before, and it failed. It didn't last very long for that reason about how do you integrate and think through the sustainability of this work, and that has the model you choose has a big impact. The other thing is that we spent the first year not just jumping into improvement, although we really wanted to, but really thinking about readiness. And we called it a boot camp of sorts. And so this is about readiness of like setting up all your data systems and your flows. Is it moving from the EHR right into claims and how that moves through the system and into your quality reporting? We've thought about financial assessment, right? And so for those that may have done it before, what were your challenges? How do we set up what is going to be the cost of this? So you have some kind of visibility to that going forward, and setting up the metrics to monitor to what degree are your claims being approved, right? Being denied, for what reasons? How do we refine those workflows? And then once we kind of dove into this work, then they were prepared to actually go into a pilot site. And so now we are doing kind of the fun stuff of actually integrating care in their pilot sites. And we'll be learning a lot more. So, but I think underscoring this, you have to have this foundation to be successful. And I think Christine mentioned, like, we often see that these organizations need grant funding or use grant funding to get started. The capital isn't always there. And it takes about a year to get your feet under you to really start bringing in the revenue to sustain it. This is not even, wouldn't even say this is budget neutral at this point, right? So we really need to focus on that. So speaking of financing, what we heard from groups, the hardest thing about integration is getting paid. And it shouldn't be so hard. It's very, very, very hard. And so we kind of step back and use that feedback. And so what opportunities do we have to hear from providers, hear from health plans, and really think through where should we focus some efforts on removing those barriers, because I think we all have the best of intentions to support integration, right? So let's get in the concrete operationalizing this. So we have been kind of convening folks throughout the 2024. We came up with some recommendations and opportunities, and you'll see those in a kind of recent report that came out, an issue brief of our recommendations of what we can do. But digging into some of the challenges that we heard specifically with payment is that in the commercial setting, plans are often carving out mild to moderate behavioral health, and that causes some hiccups and more complexities in organizations that we have to work through. As well as delegated entities. And so the more entities that a practice is delegated through, so think about the IPA and MSO, right, that capitation may not be flowing through, and it may be only for medical care and not necessarily behavioral care. So you're getting paid in different ways. And how does a practice, particularly a primary care practice that's trying to serve a whole panel of patients from different payers, manage and separate medical from behavioral? That's not how a real visit happens, right? In real life. And then so I think the takeaways from what we could do imminently, I'm going to call it a few because it's not the like super fun stuff, but it's actually some low hanging fruit. One of them was credentialing processes. The variation in credentialing, the differing requirements, it puts a lot of burden on primary care practices. And it's one reason, like, trying to work through that. That's why Christine needs this project manager. We need focused staff that aren't even generating visits and revenue to dig through this. And then I think there's other opportunities for health plans to come together. Health plans want this to happen. Practices want this. We see our purchasers building this into their contracts and setting requirements for depression screening and follow up. And so we have a lot more kind of pressure and accountability to do this, besides it being the right thing to do. And so health plans could do more to champion this. And I think to Jennifer's point, do more together. It's not a different message. It's not a competitive differentiator at this point because frankly, California is so far behind many states in this country, which like that just hurts my heart to say and admit. And was pretty shocking for me when we started looking nationally. And so for us, we're going to be running some work groups in the new year with health plans to really collaborate on these issues. So you'll learn more from us in that. And then I will end on saying, a year in, just 1 year, just doing foundational work, our organizations collectively had an improvement rate of 19.5% for depression screening and follow-up. And what that means concretely, that is in 1 year, they screened, I think 38,000 more Californians than they did the previous year. And so if you can accomplish that in 1 year with support, and we're not even in the pilot site and actually doing all the workflows, can you imagine what we could do if we concentrated efforts here and did that at scale in California? It would be tremendous and transformational.
That is incredible to hear. A lot of great work. I'm so excited to see where it goes in the next year. Thank you, Crystal. So Sharmila and Mariana, over to you all. So Crystal talked a little bit about these opportunities for us to come together on sustainable financing for behavioral health integration. From your experiences in driving broad systems change across the state, what other opportunities are you thinking about when considering how to build a more robust and integrated behavioral healthcare system? Sharmila, let's start with you.
All right. Thank you, Muriel. One of the first things that I believe that needs to be considered when building a more robust workforce that includes integrated behavioral health is to really understand the current landscape and the challenges that we face in meeting the needs of Californians with behavioral health issues. I think we can all agree that California's behavioral health workforce is under significant pressure. Workers are leaving the field. There's an increased burden of physical and behavioral health care needs, especially after the pandemic. The existing workforce does not necessarily reflect the diversity of California, and those long-standing shortages, while demand continues to increase, is a very difficult challenge that we face. And those challenges result in limited availability of behavioral health providers, increased costs that are passed on from professionals and insurance coverage gaps, which increase the real cost paid by consumers, compromised quality of care, and access is further constrained by geography, ability to pay, and cultural competency. So to really address these needs, HCI developed a statewide data-driven strategy. And I want to emphasize statewide. We alone as a state department cannot solve the problems that we are facing. And so we hope that this is a strategy that others can adopt and learn from and employ some of the findings into their work. So we accomplish this strategy through supply and demand modeling, strategic planning, and of course, stakeholder engagement. And this work will be linked in the chat so you can take a more in-depth look as we have limited time here. But I wanted to kind of go over some of the initial findings. That all behavioral health roles examined have a statewide shortage. The highest shortages being in non-prescribing licensed behavioral health clinicians, which were licensed marriage family therapists, licensed clinical social workers, licensed professional clinical counselors, and psychologists. And the most severe shortages geographically were in the Northern and Sierra and San Joaquin Valley regions. We also noticed that there are many racial and linguistic disparities and lower access to care for certain populations, especially our Medi-Cal population. And also, many behavioral health professionals were unable to work at the top of their license. There's a lack of supporting allied health professionals and certified roles. But we did know that there was a lot of data that was severely lacking for these professionals. So we are continuing to work in that area. In light of these findings, we believe that HCI should take a multi-pronged approach to supporting the behavioral health workforce, which includes significant investments in training capacity, clinical supervision opportunities, and retention, all while focusing on equity so that we can build a workforce that reflects California's diversity. We also enable data collection and sharing about behavioral health workforce, especially as it pertains to allied health roles and certified roles. HCI is also very committed to exploring innovative solutions, such as supporting emerging behavioral health roles like wellness coaches, and understand the shift and changes that are always happening in behavioral health. And we know that these models will shift, and we will need to think creatively about how do we increase the behavioral health workforce. Through our strategy process, it was very clear that there were interventions that were outside of our scope that may be required to achieve workforce and access goals, like looking at financial incentives, looking at work settings like telehealth, thinking about their education that they currently receive, providing more training, and even looking at their scope of practice or work. I'm hoping that with this knowledge that we receive from this strategy process, that we can begin to address workforce shortages collectively. Now I want to share something pretty exciting. With respect to integrated behavioral health, HCI has entered into an agreement with the UCI School of Medicine. And this program supports 3 Train New Trainer fellowships: primary care psychiatry, primary care child adolescent psychiatry, and primary care training and education in addiction medicine. These programs are designed for primary care providers who work in internal medicine, family medicine, emergency medicine, pediatrics, and obstetrics and gynecology. And the goal of these fellowships is to train these primary care providers how to complete evidence-based substance use screenings, psychiatric interviews, effectively diagnose and treat commonly encountered substance use and psychiatric conditions, and also teach these principles, hence train the trainer, to their primary care colleagues. And these programs really help support our mission by encouraging primary care providers to provide behavioral health care services. And since 2019, since the program's inception, HCI funding has supported over 900 scholarships to these providers. And what's really exciting, and I think the most important point to take back from this program, is that when we train primary care physicians on behavioral health, we are essentially creating a new behavioral health workforce within our medical system. But we're optimizing the current workforce that we have. And of course, this is not the only program that HCI has. Of course, we're meeting the needs and addressing gaps in our workforce, and we have many other programs like scholarship, loan repayment, and recruitment and retention programs that are increasing the number of appropriately trained behavioral health professionals. So please visit our website because we have a lot of more information on these programs. But as mentioned earlier in my introduction, in the coming years, we will be receiving a large amount of behavioral health funding. And our strategy work will really help us focus our resources on the greatest areas of need and support the whole person through these and other programs that can focus on integrated behavioral health. And I'm hoping with partners like you on this panel, I am hoping that we can all work together to really think through how we can scale up integrated behavioral health, not only through our workforce mechanisms, but also through those interventions that maybe, again, outside of HCI scope, but our partnership alone can make things more accessible and more helpful for the Californians that we serve. Thank you, Muriel.
Thank you. It's great to hear some funding for some very important work. Mariana, over to you.
Yes, thank you, Sharmil, for presenting the important work HCI is doing to address the behavioral health workforce shortage. I'm a licensed clinical social worker, and I've been fortunate to work in systems that employ promotoras, peer support specialists, SUD navigators, and community health workers. And this is a group that we bundle together and call community connected workers. And they're essential for eliminating health disparities because they're trusted messengers to groups that are sometimes hard to engage. They can also enter the mental health workforce more quickly than licensed therapists while effectively delivering evidence-based treatment. Given our behavioral health shortage, it's important to develop solutions that don't require a master's degree and licensure. One example is the Lay Counselor Academy, which has been utilized across the state and also nationally, and trains up, and it trains up lay counselors to enter the mental health field directly through experience and practice, and they effectively provide high quality mental health counseling to those in need. I also want to plus one, I think it was Christine who talked about the collaborative care model and Concert Health. Concert Health, beginning in January, Sutter will coordinate with them to co-manage treatment for Northern California patients who experience a broad range of behavioral health disorders, including anxiety, depression, attention deficit disorder, bipolar disorder, and post-traumatic stress disorder. Next, I want to talk about a system that addresses mild, moderate, and severe. So it's because as a clinician who's seen patients, most of my experience has been seeing patients in jails. And the fortunate thing in jails is that we treat everyone out, whether it's mild, moderate, or severe, because that's the right thing to do. And so the next model, certified community behavioral health clinics, we call them CCBHCs, has been a model of integrated SUD, primary care, and mental health treatment that has scaled in many ways nationally and has started to scale in California. So I'm hopeful that we can do that here. And let's see. And that's the other model that I'm thinking about that I really want to push forward to, that goes in between mild, moderate, and severe, are sobering centers. So I hope that there's a mechanism through CalAIM to bill Medi-Cal for sobering care, and I hope that commercial plans can come to get to the table with public health plans, and also bill for those systems, because it's not just Medi-Cal recipients.
Thank you so much. So now I'd like to ask each of our panelists to reflect on your own experiences along with what we've discussed here today. And we've got a lot of people in the audience representing different sectors across the healthcare system. What is one thing you really want to make sure our audience walks away with today in terms of opportunities to work together to advance integrated behavioral health? Sharmila, let's start with you.
All right. Thanks, Muriel. Really, one thing? I think I have maybe three. Real quick, though. One big lesson that we learned from our strategy work was that HCI alone cannot address the behavioral health workforce challenges we are faced with today. And so that's why our strategy is a statewide strategy. And we're hoping that it influences and will drive the actions of others in our behavioral health ecosystem. So to that end, I would say building collaborative partnerships, really focused on training and workforce development through programs like the Train the Trainer program I just shared earlier. Also, policy advocacy and funding. Financial incentives like considering increasing reimbursement rates. Improving compensation for behavioral health professionals, lowering tuition, using telehealth, having flexible work schedules, reducing administrative barriers. And kind of a really concrete example is more specifically revisiting our current graduate medical education requirements to include behavioral health. That would be a really significant change. And lastly, I would be really remiss if I didn't talk about the incorporation of allied health professionals into integrated behavioral health. As Mariana mentioned, these are really key positions, and this is a very key strategy because they provide essential support to clinical care teams. And so that's kind of my quick response. Thank you.
Thank you. All right, Jennifer, over to you.
Sure. So yeah, I think doubling down a little bit on what I said before about, this is going to take a village. I mean, solving for mental health access is not one solution. No, one solution is not going to help us there, because it's complex. Stigma plays a role. Workforce shortages certainly play a role. For mental health care, individuals are often left to navigate this very complex system. So even as we're building out different things, and we haven't talked about school-based care, but that's another piece of the puzzle. So I think that just hearing the different individuals speak and just all the great work that's going on, it really reinforces to me, how do we come together? How do we make sure that we are developing those synergies, working in partnership so that we can help individuals to navigate and find what they need? I think more is great and is so much better, but also if it is hard for individuals to find that care and understand what's available, then we're not really meeting the need. And I think that is going back to the integrated behavioral health, a place where it helps so much with navigation. It helps with individuals just having that conversation with their trusted primary care doctor. You said, when you said sort of personal experience, my brain immediately went to both my elderly father and my son when he was a teenager saying, hey, like when I went to the doctor, they asked if I'd been feeling down or depressed, like what's up with that? But it didn't feel like an unusual conversation to them. And so I think that just helping to break down that stigma and helping to connect people to care is such a strength of collaborative care. So I've loved hearing what everyone is doing and just thinking about all the ways that we can stay connected with our different roles that we have to really come together to help to solve this issue.
Thank you. All right, Mariana, can we go over to you?
Yes, thank you. So I think I have two points I want to make. I just want to put another plug for sobering centers because they do relieve the pressure in emergency medical system to provide low barrier point to substance abuse treatment. And in 2023, I believe, the National Sobering Collaborative released standards of care. And so hopefully we can drop a link into the box. And the other thing that I want to just highlight here is a historic shift happened in 2023 when the Federal Harm Reduction Framework was released by SAMHSA. And the framework now recognizes the importance of multiple pathways to recovery and acknowledges that individuals may not be ready for abstinence and to stop using drugs. And so these interventions not only reduce the harms associated with drug use, but also serve as a bridge to treatment. And this represents a shift away from punitive policies to evidence-based strategies that prioritize human life and well-being. And I just want to also put another plug for the Lay Counselor Academy that's it's in California, I think in Modesto, and but it does work nationally. And so there's another link there to a blog about the Lay Counselor Academy. Thank you.
Thank you. Okay, Christine.
Sure. Well, I would say that the one thing I'd like to leave the group with is scaling BHI in California is completely possible. And I think to do that, all the stakeholders in healthcare, providers, payers, the state, just need to collaborate more deeply than we normally do. And I think it starts off with aligning on like two fundamental concepts, which is number one, mental health is primary care. And especially if you're a younger patient, the reason why you might be going in to see your physician is because of a mental health issue. And the second is when we recognize that treating mental health and medical care together holistically is the right model, it produces stronger clinical and economic outcomes. Not only are we addressing the mental health symptoms, but we're also getting better total health. And then we're reducing costs because we're decreasing the total cost of care. And that's proven by all the studies. And so this is a win-win for everybody, but especially the patient. And it is a solid investment in healthcare dollars. But I think overall, we need to agree that BHI is one of the most affordable ways to treat mental health for a population and then design accordingly. And I think if we can do that, we can scale BHI across the state in the next 3 to 5 years. And that's my hope.
Thank you. All right, Crystal, we'll go over to you.
I love what you just said, Christine. I'm going to build on that because I think as a state and through the Office of Healthcare Affordability, we are engaged in a process. I think several of us on here are in that work group about how to define investment goals for behavioral health, right? How and paying for that. And at the root of it is we actually do not have a shared definition of what is behavioral health integration. I think we presume that we do, and then we get in these discussions and realizing we don't. So we can take a page from our own state. I mean, other states have done this too very successfully. I'll point to Oregon, and we're going to be kind of digging into what they've done to see what we can do in California. But we have done this as a state, and we did it with advanced primary care in the past few years. During the COVID pandemic and since. And we came together as a multi-stakeholder group and defined what do we mean by this in California, right? I'm sure it's going to look a lot like national, but are there nuances? Can we come up with these are the attributes that we would expect? And so if you are going to invest in behavioral health integration, you know what you're investing in. You also know what you're going to be expecting to get out of that and what a high performing integrated system looks like. So I go back to is we have not done that work. We can do that. There are forums, venues, ways in which we can do it. And when we have that, then we have clear expectations to drive forward. And so with primary care, these expectations have now been adopted by the Office of Healthcare Affordability to define these standards. They've been adopted by purchasers who now build them into their contracts. So right now, when Covered California or CalPERS says, tell us about your behavioral health integration strategy, there's no consistency to those responses that they're getting and that level of accountability. And so that drives accountability of measuring our progress towards true integration. And I think at the root of this, I'm going to call out two pieces of the attributes is it has to create flexibility for the spectrum of integration. A tiny practice in the San Joaquin Valley who has one provider and their partners managing the front desk is not going to do the collaborative care model, right? That's not going to work for them, right? And so how do we create that flexibility? That integration needs to look a bit different, but there is a spectrum and we can still invest in that. And then I will circle back to part of that is how we better leverage our paraprofessionals in our primary care teams. So as part of our work, another plus to Lay Counselor Academy, our provider organizations are now training their pilot teams and those care team staff, particularly medical assistants and the community health workers through the Lay Counselor Academy to integrate the skills as where you are already engaging patients, you could be adding more value but also that awareness amongst the care team that care comes together. It is not separate conversations. And we as a state, we're not going to solve this through behavioral health specialists. It is through how do we leverage our paraprofessionals, build the skills of the current ones, and then expand that. So plus to that, but this is doable for us.
That's great note. And I love, I think, sort of the common thread across all these comments about needing to come together and get on the same page to move this forward. So we do have some time for audience Q&A. And this first question, I will direct to Sharmil and Crystal, but really encourage any of the panelists to chime in as well. It actually, I think, kind of builds off of Crystal where you just left off. So how can we encourage the addition of paraprofessionals like peer counselors, wellness coaches, medical assistants, and community health workers as team members working in support of behavioral health integration?
Yeah, I can start, and then Mariana, happy to have you chime in with me. I think that integration of those professionals is a prevention and upstream solution that we're completely missing, I think. And I feel like we have to ensure that others are educated on their scope, skills, roles, and how they can essentially support the clinical team. We have to integrate that. And ensuring that they're part of this collaborative care team and being able to contribute their skills. I think that what happens is that there are a lot of people who cannot work to the top of their license. And so what they're doing is the paraprofessionals are able to open up their time so that they can serve those with more serious mental health needs. So that I believe is a very strong strategy that we need to integrate more. Thank you.
Yeah, I'm happy to chime in and what paraprofessionals actually bring to the table. I'll just give an example. I operated a walk-in mental health clinic in Contra Costa County, and we had 2 peer support specialists. So people who actually went through the system of care that worked on the team. And they were able to engage people in wherever they were. Sometimes people, families brought in their loved ones for treatment, and maybe they weren't their loved one wasn't ready, and so they're able to engage people and talk to them in a way that brings them in and addresses them where they are. They're also Lake Counselor Academy trains up people in different languages. It's really hard to do behavioral health care through a language line. It just is. It's hard to engage. It's hard to build rapport. So you're able to access different populations in different languages. And just like, you're also able to build on when they're coming through the door, and also when they're in recovery from mental health or SUD. It's a way of keeping them engaged in the system and keeping them healthy. So there's a lot of different paths. We don't in any of the systems that I worked in, we didn't expect people to, or there was never a mechanism for them to diagnose. It's more of a supportive person with the clinical team that helps to treat the patient where they are.
I'm going to jump in. There's what could be and the potential, and how do you really operationalize this and make it real? And so I think in parallel, and HCI is moving this forward. It's you have to have funding to train those folks, right? And the cost that takes. The only way we meet the needs in the San Joaquin Valley is training paraprofessionals to do this. But if that medical assistant's leaving that practice or taking that time away to be trained, who's doing their job, right? That's burden on the practice. And so many folks don't engage in that. I want to put a plug out there. We are underutilizing funding for training. And so through DHCS's PATH program and technical assistance, which the new round is about to open up in January. So if you are a Medi-Cal provider or practice, you can apply for funds, and you can select that those funds be used for Lay Counselor Academy, right? And so I think how we better, in our work, we think about how do we better identify these sources of resources for practices and do that matchmaking. And that's a critical piece. And I think we are not taking that all the way to the front lines to know. And then we have to think about then if you're going to invest in that, you need a parallel process of how do you actually utilize that person once they're trained. And so I think that's some of the guidance that we can do improvement work. I don't think that's unique to CQC. I think that's guidance health plans can provide, right? Many health plans not only have coaches, but other staff that are think about provider network folks that are reaching out to practices and have relationships that we could be cascading some of that support to them. I don't think it's tremendously difficult. It's just a matter of we haven't been able to get that in front of the front lines and in their hands.
Thank you. I'm going to try to get to 2 more audience questions before we hit time. So the next question I'll direct towards Mariana, but again, anyone, please feel free to chime in. Could you please tell us what opportunities you see to leverage CalAIM enhanced care management and community support providers and services to enhance or increase the impact and success of integrated behavioral health efforts for the Medi-Cal population?
Yes, so CalAIM is definitely, we're 1 year in, and there are a lot of different things coming down the pipe. There have been behavioral health payment reform. There has been documentation reform. The other one is now through CalAIM, we can fund sobering centers, and we talked about that before. Respite care. I can't list them all. I think there's 14. I'm happy to put a link in the chat. We have a fabulous California Healthcare Foundation has a fabulous CalAIM website that talks a lot about that. And so just want to put out there's a lot of reforms coming down the pipe. And the one that sticks out to me is integrating SUD treatment in a lot of different into county behavioral health systems. And so the devil's in the details. The state is still working out the details about how this will play out. That's a really exciting piece, because a lot of historically, SUD has been kept for many reasons. It has been kept to the side of mental health, like even in like an electronic health record. It's usually like there's a firewall so there's not a flow of information going amongst the providers. So I'm looking forward to the integration of SUD into healthcare and into mental health.
Thank you. Okay. And our next question is for Christine and Jennifer. Can you please speak to if or how you are implementing collaborative care for pediatrics, Medicaid CHIP in the community or school-based care?
Sure, I can start. So I would say with integrating pediatrics or scaling integrated behavioral health models in pediatric settings, there is strong evidence, but there is less evidence. And I would say in places where people are relying on like what are the cost of healthcare savings or the financial return, it's harder to show in pediatric populations. So I think that's been a bit of a barrier. We are partnering with some provider groups who are scaling evidence-based models, and it's very effective. And obviously there's such a need in youth populations and with families. So I think that that it's definitely something that can be done. It just seems it's been lagging a bit. And then, talking about school-based care, the CYBHI, the Child Youth Behavioral Health Initiative, is, we talk about, embedding care everywhere. That is, bringing care in schools into network for all health plans, and just really excited about. I mean, it's definitely bumpy, and it's a new muscle for schools and for some health plans as well. But I think it's so important to be able to provide that access and that screening and those resources, which also certainly includes paraprofessionals. And I think reimbursement for different paraprofessionals and school professionals is a real strength of the model. So, Christine, let me pass it to you.
Yeah, absolutely. I would say that in our markets, largely, we do not have large pediatric populations. And so in the markets where we do, the one difference that we're all kind of aligning on is our collaborative care program right now is 100% virtual. But if we were to launch it in markets where we're offering it to pediatrics, we'd also want a physical location as well, because you'd want to be sure that the family could get care in person if that was more suitable. The other place we see pediatrics is in the emergency department. You get everything. And so I think just stepping away from the BHI model, one of the things that's really, really important to us is how do you start to understand the best behavioral health services in a community and be able to connect that patient very quickly to the right service. Like right now, if you're a pediatric patient in the emergency department, you could spend like 3 days just waiting for the right referral and then someone to accept your referral. So a lot of our focus has been spent on how do we make sure that we cut that time drastically so that by the time you get your evaluation, we could have you discharged within hours. And I think that would make a huge, difference for families.
Thank you. We are at time. There are so many incredible audience questions. I wish we had time to answer them all. Thank you so much to our panelists for a great conversation today. And thank you to our audience for taking the time to join us. We will follow up in the next few days with a recording of the event. So make sure you're registered for the event and please sign up for our newsletter to stay up to date. Thank you all, and please have a great rest of your day.
Thank you. Bye-bye.